Bismillah ar-Rahman ar-Rahim. Today, the subspecialty lecture will be about eyelid malposition and facial palsy. What we mean by eyelid malposition is like entropion, ectropion, ptosis, and retraction. And today lecture will be only about entropion and ectropion. Ptosis and eyelid retraction will be covered by another lecture. Regarding entropion, we mean by entropion that inversion of the eyelid margin. So the lid margin itself is inward deviated, and that can be either cicatricial, involutional, congenital, or spastic. In other words, entropion is a clinical finding, but the diagnosis, you need to mention the cause. Like this is cicatricial entropion, involutional entropion. But if you say just entropion alone, this is just a clinical finding without a diagnosis. So diagnosis, you need to indicate the etiology. Cicatricial entropion it's common in our area as a sequel of ultracoma. How patients with cicatricial entropion present? They present with entropion inability to correct the entropion by downward traction of the lower lid or upward traction of the upper lid. You will observe scarring and shortening of the conjunctiva and or the tarsus when you flip the eyelid, along with corneal and conjunctival irritation and sometimes scarring and erosion. What clinical test or lab test you do for cicatricial entropion? We can do immunological studies if you're suspecting mucous membrane pemphigoid. And if there's active trachoma, you can do culture or herpetic infection if there is evidence of herpetic ocular infection. واضح الصوت شباب؟
ايه دكتور بيرفكت
يعطيك العافية. This patient with entropion in the lower eyelid, this sign just to highlight for you the meibomian gland orifices. If you can see the meibomian gland is in this, is the arrow clear for you?
Yeah, very clear.
The mouse. You see the meibomian gland orifices here in a normal position, and here is pulled inward. And this is typical for cicatricial entropion, that you see the scarring more in one part of the eyelid and the other part is less evidence. And this is a nice photo to show you that this is the meibomian gland orifice is pulled centrally, while it's medially and laterally is less pulled, indicating less scarring in the medial and lateral part of the lower eyelid. However, it's more severe scarring in the center of the eyelid, as evident by the meibomian gland orifices pulled inward. So how we treat cicatricial entropion is medical treatment by lubrication, and sometimes we can use temporizing measure like bandage contact lens. However, the definitive treatment is surgical treatment, and how we do that, there is several surgical procedure described, and it depends on your comfort, which surgery you are familiar with, you can choose. So what surgical option we have? We have anterior lamella reposition, and we have lid margin rotation, tarsal fracture, a mucous membrane grafting if there is very severe conjunctival scarring, and you can do a combination of the above procedures. This patient with cicatricial entropion, this is what we mean by anterior lamella reposition. So we do split between the anterior lamella and posterior lamella and resist the anterior lamella superior and lower the posterior lamella, and you can suture after that, after doing adequate anterior lamella separation. This is what we mean by lid margin rotation, that you do a complete cut in the tarsus, then after that you rotate the lid margin by placing a suture in the upper part of the tarsus all the way, and you exit the suture just above the eyelashes, like showing in this picture, and you can place 2 or 3 sutures to get the adequate rotation that you need. Sometimes you can combine the anterior lamellar recession along with the lid margin rotation, as we mentioned before. Involutional tropin, this is a result of lower eyelid horizontal laxity, and usually there is medial and lateral horizontal laxity, but more with lateral horizontal laxity. Also, there is evidence of eyelid retractor dehiscence, and it's more evident in patients with prominent eye and the malar bone, maybe, I'm sorry, prominent of malar bone under the eye. So the meaning the eye is a little bit sunken. And also it was found to be more in patients with shorter tarsal height. What's the clinical feature you see with these patients? You see lateral canthal laxity and also medial canthal laxity, epiphora secondary to reflex tearing from excessive lacrimation or reflex tearing. What clinical evaluation you do? You do a distraction test for medial and or lateral canthal tendon. And if the eyelid laxity is more than 7 or 8 millimeter from the globe, that's indicating significant laxity in the lower eyelid. Another thing you can do is a snapback test. So after distraction the lid from the eyeball, the eyelid doesn't return back to normal position without one or more blinking, that indicating laxity in the tendon. It's really important to highlight here, involutional entropion is almost always in the lower eyelid. Involutional entropion doesn't happen in the upper eyelid. So involutional entropion happens only in the lower eyelid. This is a patient with, as we can see, the distraction, and you can pull the eyelid from the eyeball, and this one is more than 11 millimeter, indicating significant laxity. This is a side view to show you the entropion for the lower eyelid. Here I want to show you that you can see the entropion in the lower eyelid is uniform, meaning the severity of the lower eyelid is entropion is symmetrical or symmetrical in the medial part, central part, and the lateral part. This is opposite to what we just mentioned about cicatricial entropion, where the entropion is more on one side compared to the other side. Involutional entropion, the lower eyelid entropion is uniform along the eyelid. Other thing, after pulling the lower eyelid, the entropion will correct. Then after blinking, the patient will have entropion again. And this is one of the clinical finding you do to confirm your diagnosis with involutional entropion, that it's improved with pulling the lower eyelid away from the eyeball, and it returns back after blinking and or a forceful closure of the eyelid. So regarding involutional entropion, the treatment for it, again, medical treatment as a temporary measure. However, the definite measure is surgical entropion correction. And if the patient is having mild to moderate entropion, we can do lateral canthal strip procedure with horizontal shortening of the lateral canthal tendon, with reapproximation of the tendon to the inner aspect of the lateral orbital rim. However, in severe entropion, it requires reinsertion of the dehiscence lower eyelid retractor to the inferior tarsal plate with lateral canthal tendon strip procedure. This just to briefly explain the lateral canthal lateral tarsal strip. It starts by giving local anesthesia to the lateral canthal tendon area. Then after that, we'll do canthotomy. Then after that, inferior cantholysis to release the lax tendon. Then after that, we determine the amount of the skin need to be, and the tarsals need to be excised by pulling the eyelid all the way till reach the lateral orbital rim, and define or decide on the amount of the skin and tarsals need to be excised. After that, we created the lateral tarsal strip, and we separate the anterior lamella from the posterior lamella. Following that, the epithelial lining at the posterior surface of the tarsals along the lid margin need to be removed to prevent epithelial inclusion cyst. Then after that, it will be sutured to the Wetland tubercle from the inner side of the orbital rim to make the eyelid opposing the globe nicely without a space between the globe and the lower eyelid. Then after that, it will be sutured the skin at the lateral canthal area. Regarding lower eyelid retractor reinsertion, it can be either done through subciliary incision or through the conjunctival incision, whatever you feel comfortable with. And to start by doing subciliary incision, like in this picture. Then after that, we dissect between orbicularis and the lower eyelid retractors. Then after that, after identifying the lower eyelid retractors, it will be reinserted again to the lower part of the tarsus with three or four interrupted fical suture, and they need to be spaced in a way that it's prevent from overcorrection, because when you do lower eyelid retractor, it's good only to reinsert it, not to make a huge uh, uh, shortening in the lower eyelid retractor to prevent consecutive lower eyelid ectropion. And this is just to show you the picture laterally. Just reinsert the lower eyelid retractor in the lower part of the tarsus, and then after that you close the subciliary incision. Regarding the acute spastic entropion, it's really related to ocular irritation and inflammation of the conjunctiva and lower eyelid, and it's really important to identify the cause for it and treat the cause, and after that the eyelid spastic entropion will improve. What the clinical feature you see in these patients, you will see sign of lower eyelid inflammation or edema, and often there is lower eyelid horizontal laxity, along with corneal epithelial changes from the rubbing eyelashes. So the key diagnostic criteria for spastic entropion is resolution of the entropion when the cause of the irritation is removed and the inflammation resolves. In some cases, because of the constant involution entropion, may eventually be seen in patients initially present with spastic entropion because of the long-standing spastic entropion laxity in the lower eyelid develops. How we treat acute spastic entropion? We treat them by medical treatment to remove the underlying cause of ocular irritation, along with ocular lubrication. Sometimes we may need bandage contact lens. Botulinum toxin injection to the orbicularis muscle is one of the treatment options for these patients as a temporary measure. Surgical method, we can do a quicker procedure as temporizing measure. And if we remove the irritation factor and still there is entropion due to laxity, we'll do what we explained before for involutional entropion correction. Entropion is the opposite of ectropion is the opposite of entropion, which meaning the outward deviation of the lid margin, and this again can be either congenital, involutional, paralytic, cicatricial, or mechanical. As we mentioned, entropion and ectropion are a clinical finding. If you want to make a diagnosis, you need to define what cause for this ectropion or entropion. Involution entropion, which is the most common one, is lower eyelid laxity again, which involved the lateral and medial canthal tendon. And because of the gravitation, there will be outward deviation of this lower eyelid, along with sometimes these patients are having prominent eyes and hypoplastic malar bone. It was observed that patients with ectropion, involution ectropion, they have high tarsal height compared to normal people without eyelid malposition. As we mentioned before, lower eyelid retractor dehiscence may play a role in the lower eyelid ectropion, like what we mentioned in the entropion. So what the clinical feature is lateral canthal tendon laxity, along with the medial canthal tendon laxity, and also epiphora and secondary reflex tearing. So patient with involutional ectropion will have a positive distraction test and positive snapback test, as we mentioned in involutional ectropion. Again, we highlighted that why patient they develop ectropion, because they have either prominent globe on the malar bone is hypoplastic, and also high the tarsal height is a little bit more than normal. These are predisposing factor for involution ectropion. Treatment for involution ectropion, like what we mentioned in the entropion, it will be based on correcting the horizontal laxity with the lateral tarsal strip and the vertical laxity with lower eyelid retractor reinsertion. And this is again, as we mentioned, for surgical correction, similar to the ectropion regarding the horizontal and vertical lid laxity correction. Cicatricial ectropion is a result from the anterior lamella scarring or shortening, and this can happen either in the upper eyelid or in lower eyelid. Sometimes the patient may have lower eyelid laxity along with the cicatricial ectropion, and that needs to be addressed at time of surgery for proper surgical correction. Because of the chronic cicatricial ectropion, there will be keratinization of the eyelid margin and sometimes of the palpebral conjunctiva. Again, we'll see ocular sign irritation and exposure, and this will be exaggerated when the patient opens their mouths. What the cause of cicatricial entropion? The most common cause is either trauma or excision of the skin in case of lower eyelid blepharoplasty. Chemical burn also is a cause, and skin disease that causes scarring in the skin, it also may be a cause like scleroderma. So surgical correction is the treatment for cicatricial entropion, and this sometimes, as we mentioned, can be associated with horizontal lid laxity that can be or need to be addressed at the time of surgery. The standard approach for vertical cicatricial traction is surgical incision and relaxing at the incision. And sometimes we need to do replacement of the anterior lamella with full thickness skin graft. In some cases, the ectropion may be corrected only with mid facelift if there is only mild deficit in the skin in the lower eyelid. And that will eliminate the need for a skin graft in the lower eyelid. This patient with ichthyosis, as you can see from her clinical picture, and she's having ectropion in both our lower eyelid, and the standard treatment for this patient is full thickness skin graft. However, in this patient, we tried putting a mucous membrane graft taken from the mouth because the mucous membrane in this condition is not involved, and that will give a better improvement in her eyelid position. And this is what we did. And you can see in the picture here, this is a mucous membrane graft after being placed, and this is a pre-op picture, and you can see resolution of the cicatricial ectropion. And this is her picture again, and this is after lower eyelid ectropion, and still she has upper eyelid ectropion, and this is after placing the mucous membrane graft in the lower eyelid and also in the upper eyelid, and the patient is able to close her eye normally now. We'll move now to facial palsy, unless there is any questions so far. Is there any question before we move to facial palsy? No? Okay. As you know, facial nerve is really vital for person well-being, functional, psychological, and also emotional. So patients with facial palsy, they will have really severe compromisation on their eyelid function, mouth, vascular, facial muscle function, along with their psychology, and also will be isolated because of their facial appearance that is really making them embarrassed whenever they go. So it has a major impact on the patient, the whole function. Some anatomical consideration, as you know, the facial nerve contains around 10,000 nerve fibers originating from four brainstem nuclei. A facial motor nucleus control the muscles of facial expression, and superior salivary nucleus innervates the lacrimal gland and salivary gland, and that it travels along with the facial nerve. Nucleus solitarius is receiving fibers from of taste from the anterior two-thirds of the tongue. Trigeminal sensory nucleus getting sensory fibers for a small portion of the external ear also goes with the facial nerve main trunk. And this is a diagram just to show you the path of the facial nerve. This is originating from the brainstem, and you can see the different nuclei that present in the brainstem, and they join the facial nerve along its journey through the ear. Then after that, exit the ear through the stylomastoid foramen. Then at the parotid gland, it divided in several branches that supplying the whole face. And this is the different branches we see during anatomical dissection. And in a real life and a real anatomical lab dissection, you will not see the branch as beautiful as this. This is more of just a simplification of the facial nerve branching pattern. However, in real life, it's more complicated than this picture. When you talk about facial nerve palsy in ophthalmology, we are talking about lower motor neuron lesion, because in the upper motor neuron lesion, the upper part of the face is reserved, and these patients, they don't come to ophthalmology, and they go to neurology. So what we see in our clinic is a patient with a lower motor neuron lesion. And what are these causes for lower motor neuron facial nerve palsy? It can be infectious from herpetic infection, inflammatory, traumatic, iatrogenic from trauma during surgery in parotid gland, for example, or middle ear, for example, congenital, idiopathic, meaning unknown, and neoplastic is another cause. The most common cause for facial palsy, lower motor neuron facial palsy, is a Bell's palsy that it's really exactly not well determined, but some hypothesis pointing toward possible herpetic infection. What are the ophthalmic presentation of facial nerve palsy in adults? It's eyebrow ptosis, lag of thalamus, ectropion, upper eyelid retraction, exposure keratopathy, and epiphora. This patient with the facial palsy on the right side, and you can see the ectropion in the lower eyelid, along with the lag of thalamus, as you can see in this eye. The patient, he has malpostions ptosis in the right side compared to the left side. However, he has a bilateral brow ptosis because of the senile changes. Investigation, when you get a patient with a facial palsy, we ask for investigation, and typical investigation involved MRI and CT scan along the path of facial nerve palsy. If the facial palsy is typical for Bell's palsy, maybe we need wait not to rush for imaging, because most of the patient, they improve by themselves. However, if the patient is having recurrent facial palsy or not typical for Bell's palsy, or having bilateral involvement of facial nerve palsy, imaging is really mandatory in these cases. Lab investigation depends on the clinical finding. If you expect a patient to have, for example, sarcoidosis or infectious causes for the facial nerve palsy, we need to ask a lab test based on the clinical finding. So this is, again, imaging. We ask for it if there's slow onset of symptoms, no return of function after 6 months, or recurrent bilateral causes of facial nerve palsy need to be imaged. What is the management of ophthalmic manifestation of facial palsy? Patients with facial palsy really need to have a multidisciplinary approach for proper management. And also we need to look if the patient is expected to have recovery, like in patient with Bell's palsy. However, is recovery not expected? For example, a patient who had facial nerve palsy after removing of parotid gland tumor, where the nerve was involved and was removed. And in this patient, improvement is not expected. So if there is expected improvement, we need to take the temporary measure to help patient passing the critical period where the eye is really affected because of the severe exposure keratopathy. So topical ocular lubrication, extensive lubrication is needed, along with sometimes closing the eye with tape at night that will help lubricating the eye at night. Temporary tarsorrhapy with a suture or with cyanoacrylate glue, another way of helping the ocular surface to be well lubricated. Another measure can be done is botulinum toxin to induce temporary ptosis till the recovery of the facial nerve happens. This is just to show you a picture for temporary tarsorrhapy, and it's placed upon the patient need and can be mild, limited to the lateral part, or can extend to the central part of its facial nerve palsy is very severe. This patient had Bell's palsy, so he improved without any intervention, and you can see the improvement after a few weeks from the onset and the return to full function of the facial nerve on the right side. So if the improvement is not expected, we need to take the permanent measure now, and this involves surgical correction. For patients with lack of thalamus, we can put upper eyelid weight, either with gold weight or platinum chain, along with eyelid retractor recession to help improving the lid closure, along with inducing mild ptosis. For lower eyelid drop and ectropion, we need to do horizontal lid tightening along with the mid-face lift to have a better support for the lower eyelid. Sometimes maybe we may need to use a spacer to lift the lower eyelid to appropriate position. Brow ptosis and blepharoplasty also can be done according to the severity and the desire for improvement in the function and cosmesis requested by the patient. This is just a video to show you how much improvement we expect with weight placement in the upper eyelid. This patient with the facial palsy in the left side, as you can see, the patient is blinking. This is without weight, and this is after putting a trial weight, and you can see the improvement in the blinking after putting the weight in the upper eyelid. So the idea of weight in the upper eyelid is to improve the blinking and lubricating the ocular surface in a better manner. This is a gold weight placed in the peritarsal space, and we can use again a platinum chain, which is a smaller and better cosmesis for the weight bearing in the upper eyelid. This patient with the facial palsy on the right side, and you can see the severe ectropion in the right side because of facial palsy. And this is this patient need to have lower eyelid horizontal tightening, along with the mid-face lift to help correcting the lower eyelid. Sometimes a spacer also may help in correcting the lower eyelid, and sometimes we may use sling material for correcting the lower eyelid malposition with the fasciolata, or sometimes with absorbable sutures. Lateral tarsorrhapy is another way of managing the exposure keratopathy is in a patient that's not expected to have a recovery. Myself, I don't prefer much the lateral tarsorrhapy because it's really affecting the cosmesis in a significant way, and most of the patients, they don't like it much. And this is a way of doing lateral tarsorrhapy is by splitting the anterior and posterior lamella from each other. Then after that, deepitalize the posterior lamella, as we can see in this picture. Then after that, we suture the tarsus, upper tarsus to the lower tarsus, and also the lashes anterior lamella with sutures again with a separate suture. We can use 2 to 3 sutures to create the lateral tarsorrhaphy. And this is the final picture at the end of the surgery. When you do a tarsorrhaphy, you need to go all the way till you reach nearby the lateral limbus and you stop at that position. What I prefer more is paracentral tarsorrhaphy, unlike in this patient. This patient has severe lack of thalamus, and this is the tarsorrhaphy we put here, just lateral to the puncti in the upper eyelid and lower eyelid. And this is the cosmesis. I found it to be better accepted by patient, and also the function providing really a good function and improve the ocular lubrication. Patients with facial palsy, they may present with epiphora, and that can be either from reflex tearing because of the dry eye, and also along with that is paralytic tropion and inability to close the eye, and that will lead to a pump failure of the tears from the eye to the lacrimal system. Hypersecretion from aberrant innervation of the lacrimal gland is another cause for epiphora, and these happen months after the insult of facial palsy. This picture just to show you that in pediatric age group, facial palsy may lead to entropion. Like in this patient, she had facial palsy in the right side secondary to a middle ear infection. And this is the entropion developed secondary to facial nerve palsy. And this is her surgical, this is her eyelid picture after surgical correction. This is another patient with mild entropion secondary to congenital facial nerve palsy. And also you can see there is lower eyelid retraction. This is the right side and this is the left side. And you can see the lower eyelid retraction in this eye that unfold with the lower eyelid, with the facial palsy in the lower eyelid, more lower eyelid retraction compared to the normal side and the left side. This patient also with the facial palsy in the right side, in the left side, and you can see the brow ptosis in the left side, along with the lower eyelid retraction in the left side because of facial palsy. So again, the lower eyelid retraction and entropion may be seen in young patient and pediatric age group compared to adult, and also the brow ptosis may be more evident in a younger patient. However, it may not be clear unless you ask the patient to contract their frontalis muscle, because in younger patient and children, the cutaneous tissue and the tendon are very tight, so it will not be easy to develop brow ptosis because of the strong attachment of the brow. However, it's really evident, as we can see in the picture on the lower side, when they contract their frontalis muscle. This is another patient showing the lower eyelid retractor. Along with the facial palsy, the patient will have also involvement of other muscle in the face, and this patient may develop a wasting of these muscle or atrophy of these muscle in the cheek and also in the brow, and that need to be addressed and explained to the patient. Following peripheral facial nerve injury with axonal damage, axonal regeneration begins at approximately 3 months after the lesion, and it may lead to inevitably to clinically evident or subclinical hyperactivity of previous paralyzed muscle. Like in this patient, he has facial palsy in the right side, and after that, he developed hyperactivity of the facial muscle in the right side after axonal repair. And you can see evidence in this patient. The right eye is smaller than the left eye because of hyperactivity in the orbicularis muscle after recovering of the facial nerve palsy in the right side. And this is one of the presentation of late presentation of facial palsy, that the eye is the affected side is smaller than the normal side. And this patient is having aberrant regeneration. So when he was trying to close or move his mouth, his eyelid closed too because of aberrant or synkinesis of the orbicularis muscle after the repair of the previously injured facial nerve. Other manifestation of or late sequelae of facial nerve palsy is post-paralytic spasm or contraction. This patient, she has a facial palsy in the left side, and she's developing spasm and contracture in the left side, and that's simulating the hemifacial spasm. And this happens all of a sudden without the patient control. How we treat this one? We treat it with the botulinum toxin. As you know, that botulinum toxin is the type of toxin that produced by Clostridium botulinum, and there is several serotypes of this toxin. The one we use commonly is type A, which is forming the botulinum toxin that we commonly use. It starts by around 3 days, and the peak of action around 1 to 2 weeks, and the duration of action around 4 to 6 months. And this is the site of injection if we want to relax the orbicularis muscle after either hyperactivity or post-paralytic spasm and contraction. This is end of the talk. If you have any question, please let me know.